We'll talk this morning, kind of a tour of my experiences in ocular melanoma. And we'll kind of take the span from the clinical side of it to some of the new frontiers in genomics, but also some of the areas that we're entering into proteomics, but more importantly, collaboration and how the small community of researchers and clinicians have really worked to try to move the field forward for our patients. Here are my disclosures. I'm a consultant for Castle Biosciences and Aura Biosciences, for which we'll be discussing some of their technologies. So as Scott mentioned, my ophthalmology career started on the East Coast at Duke Eye Center in Durham, North Carolina. And through the course of that time, I've been really fortunate to have fantastic trainees, and there's two that I hold really close to my heart. So Derek Del Monte and Paula Peason were both fantastic residents with us at Duke. Both were gifted surgeons. They were tireless clinicians, first one's in, last one's out, and both really great, curious researchers. Really, they were the best of the best that I had the privilege of working with and training at Duke. Derek was truly a workhorse on the cornea service. We were both on faculty together, and we actually were in the same satellite clinic at the Duke Eye Center of Cary. He is a very hard act to follow, from just his smooth style and easy personality. And Paula, we knew, was geared towards retina from the real beginning and was a real star. She completed a fantastic fellowship at the Cole Eye Institute. And then from there, made the move to Denver. And as soon as that happened, Derek was on the next flight out. So that was a loss for us there. But it wasn't that much longer after Derek left that I made my move to California. First time I've ever lived on the West Coast, and found a home here in Palo Alto at Stanford. And the connections to Colorado kind of continue because one of my closest colleagues on the retina service is Carolyn Pan, who is a alumnus from your fine program. And Carolyn, now you'll be happy to know, is one of our associate residency program directors and heads the retina service at the Santa Clara Valley Medical Center, which is one of our biggest teaching sites and clinical sites for our fellows and residents. And I met this guy, Matt Powers, who was one of my first residents who was assigned to me in clinics. Matt and I became good friends, and I can't be more proud of his accomplishments and looking forward to him back in the Bay Area. So all roads kind of lead back here to Denver. So I hope to come out there soon and enjoy time with friends. And I think the theme that I like to carry through is that there's keys to successful collaborations, and some of these are to have common goals with your collaborators. The second is to share ownership of projects and outcomes, and then have defined objectives. Everyone has a role and will need to be, and at the end, we want to see the end point together. And the key is fighting cancer as a team sport. Here's one of the Plumley brothers who used to play at Duke, and as we know, it takes a team in order to reach a goal. And I hope also we can go watch a ball game sometime together too, whenever that might happen. So uveal melanoma is our topic today, and we all know that it's the most common primary uveal malignancy that we see in adults. We know that clinicians do an excellent job at controlling these tumors within the eye, but we know that there's still an unacceptably high rate of metastatic disease, and that will be some of the focus of the conversation this morning. So let's just review a little bit on the current state of care in uveal melanoma. So diagnosing uveal melanomas has been something that will be an issue for all clinicians, regardless of their subspecialty, as these patients can walk into a comprehensive clinic as well as a retina clinic or an oncology clinic. We know that we recognize the darkly pigmented lesions. We can see the orange pigment, which is indicative of lipofuscin, a high-risk feature. We look at the size and the height and the location of the tumor to give us information, and also the presence of subretinal fluid, which is indicative of the tumor itself, but also might lead to symptoms that the patient may experience that actually brings them in. And these traditional risk factors have been studied and do predict the risk of growth in these patients. So now we tend to look at these as a way to stratify which patients get treated earlier versus later. And we know that not all growth of a melanocytic lesion in the choroid equals malignancy. Some of these may be just a nevus that has a normal physiologic growth pattern, but sometimes the rate at which they grow will be more indicative of trouble or not. And if you ever wanted to read an excellent primer on how to identify, look no further than Matt Powers. He wrote a great chapter on how to do this, and I'm sure he'll share it with you and autograph it too. For the residents in my oncology clinic, and probably not too different from Scott's, our patients spend a lot of time with us, and a lot of that initial evaluation is imaging. So they clog up the lanes in our photography area, but they get a lot of images. So not only do we count on wide field optos photographs to give us the scope of the lesions, but we're also doing SLR-based fundus photos that gives us kind of a true color appearance. We do wide field angiography, autofluorescence. We focus a lot on the OCT, especially for smaller lesions, and then standardized A and B scan ultrasound. And what we can see with all these different imaging modalities is that we can diagnose these tumors, especially ones that may not be as obvious, by using multimodal imaging techniques. So you can take one tumor and look at it with standard color photographs. You can then add the wide field imaging. We can look at it cross-sectionally with EDI OCT and see the characteristic compaction of the choriocapillaris with the associated subretinal fluid that we see on the OCT image. Ultra-wide field angiography shows us the punctate patterns that Matt Powers shared with us earlier. And then the wide field autofluorescence, like in the case that he also reported, shows changes not only in the tumor, but the surrounding neurosensory retina as well. OCT angiography has been of greater interest now in looking at these tumors, and I don't feel it's diagnostic, but we're learning a lot about post-radiation side effects by using OCT angiography. There are two effective treatments for uveal melanoma. The first is enucleation. Tried, true, and tested, we know that it can give us 100% local tumor control within the eye itself. Radiation therapy is also a highly effective treatment, greater than 93 to 95% local tumor control, and can be delivered in different forms. So proton beam, gamma knife, or cyber knife provides an external source of radiation into the eye, whereas plaque brachytherapy with a variety of isotopes provide local tumor control to the eye itself and is controlled by the ocular surgeon. And I believe Dr. Oliver favors the plaque platform as well. We were interested in seeing what the trends were for globe-sparing treatments in uveal melanoma. And what we're seeing is that as now radiation therapies have advanced and become a little easier for clinicians and radiation oncologists to plan, the trend is increasing for use of radiation. We looked at this recently through the SEER database, which is a cancer registry database that samples across the United States. And what we found is over a 10-year period, there's been a 14% rise in the use of radiation therapy for uveal melanoma and a concomitant decrease by about 10% of enucleations being used. Now, that might mean that people are just being more aggressive with using radiation for tumors that they would have enucleated previously, but it could also mean that tumors are being caught at an earlier time point due to greater awareness, due to greater imaging, due to the use of wide field imaging in optometry practices, for example, as part of their workup and screening that may identify some of these tumors earlier, allowing those eyes to be saved. There have been some improvements in globe sparing techniques as well, which may also be leading to some of these changes and improvements in outcomes. The first is using more precise radiation planning, which we'll talk about. The second is using choroidal tumor biopsies, which allows us to sample the tumor to give us better diagnostic information, but also prognostic information for deciding patients' risk for metastatic disease. Here we can see a vitrectomy-based biopsy being performed in a patient with a uveal melanoma. That's the cutter coming out of the tumor right now. And within the collection specimen will have large chunks of tumor tissue. And I think Dr. Oliver alluded to this as a technique that he may be favoring as well. And then finally, the complications of radiation therapy are well known, including proliferative radiation retinopathy. And now there are strategies for active management of radiation retinopathy, with several prospective studies being reported with the use of anti-VEGF therapy, and a proposal in place now with the DRCR network to be able to study radiation retinopathy in a prospective multi-center fashion. So how do we reduce radiation damage to the eye? There are several techniques that have been proposed and are in evolution. The first is to improve the way that we deliver radiation therapy with plaque radiation. So what's really happened is that there's been an improvement in the software that our radiation oncologists can use in order to make the precise planning that's required. Before, when I first started, the estimates for how large a tumor were, the geometry, were really based on just crude measurements that we'd have by ultrasound. It didn't really take into account the actual geometry of a lumpy, bumpy type tumor, or one that was smaller on one end and thicker on the other. But now we're combining not only wide field imaging, but globe imaging with either MRI or CT to give us radiation planning like you would get if I was getting treated for a tumor in my lung or in my kidney, much more focused and much more conformal. So now we can try to plan better, not to overtreat tumors, but definitely not to undertreat them or miss them either. So this is giving us better control over the radiation process as ocular oncologists. The second approach is to reduce the amount of radiation that we use when we treat these tumors. So the standard for treating a uveal melanoma, as established by the collaborative ocular melanoma study, is to treat the very top or the apex of the tumor to a very hot dose, which is about 85 gray to the apex of the tumor, which means the entire tumor, even the base, is getting a much higher dose in order to heat the tumor with enough radiation to reach that 85 gray mark. Our group had previously looked at a large retrospective series where we've been treating patients with a reduction in that apical dose. And what we found is that by reducing, by our practice, the apical dose by about 20%, we're still able to achieve the similar rates of local tumor control, but we found that there was an 18% reduction in vision-threatening complications. So suggesting that maybe the dosing that we're using, which is high, may not need to be that high in all cases, and gives us potential to try to spare vision by reducing dosing. And finally, using our wide field imaging systems to quantitate the damage that's being done by radiation therapy. So this is a study that was put together by Dr. Peason when she was a resident with us. Here we can see a tumor that's been treated with a lot of lipid exudation. The angiogram shows that there's large areas of peripheral non-perfusion. So Paula was able to actually quantitate the area of non-perfusion and give us a quantitative area measurement. And what she found is that there's a direct correlation with the actual area of non-perfusion and final visual outcomes. So greater non-perfusion means worse vision. And this, I think, is important in trying to gauge prognosis for patients, but also strategies as to which patients may benefit from a more aggressive strategy with either laser or anti-VEGF therapy. More collaboration has been brought into place as we look for improved non-radiation based treatments for uveal melanoma. The problem is that when we treat small melanomas, especially those that are found near the macula or the optic nerve, the risk for vision loss is significant from radiation therapy. So there's a company called Aura Biosciences, and they've developed a molecule which is called AU011, which is a highly targeted anti-tumor treatment specifically for uveal melanoma. Now, this is exciting in our field, where we've been basically doing the same thing for decades to try to treat ocular tumors. This is a first not only in eye, but also a first in cancer type molecule. So it's an inactivated human papilloma virus, and it has a bioconjugated engineered dual specificity molecule on the surface. it attaches to heparin sulfate molecules on the tumor, and using a near infrared light, which is essentially what we would use for photodynamic therapy, it induces oxidative damage and selective tumor death. In this illustration, these VPBs, or viral particle biconjugates, are injected into the eye, and they attach themselves to heparin sulfate proteoglycans on the surface of these melanocytic uveal melanoma tumors. So they're preferential to these melanocytic tumors. And there's damage and death done to these tumors in two ways. One is that when the PDT light is placed onto the tumor in focus, it activates the conjugated light-activated molecules, and you get direct tumor necrosis after the light activates it due to free radical oxygen import into the tumor itself. So direct tumor death is one way that this works. The second is by an immune mechanism where there is recruitment of CD8 and CD4 positive T cells. So there is an immune therapy component to this. So not only are we just talking direct damage, but now an immunotherapy component, which we know melanomas seem to be highly susceptible to. So two unique mechanisms. The treatment is not easy, but manageable. So patients currently now in the phase 2 clinical trial, which we've been a part of, receive 2 injections of the AU011 molecule. We wait about 6 hours, so somewhere in the evening, we get the patient back and we perform 2 subsequent PDT type laser treatments, so non-thermal, non-destructive. And then we follow the patients closely and repeat that as a second cycle 3 months later. Here's an example of a patient. On the left panel, we can see a peripapillary melanoma on the nasal side adjacent to and touching the optic nerve. This lesion was about 1.93 millimeters in thickness, but the patient had really excellent baseline visual acuity, about 92 letters on ETDRS testing. The patient was part of the single dose cohort, and after completion and at 12 months, we can see that the tumor has shrunk, actually about 1.8 millimeters, and the vision has remained. So this gives us 2 important data points. First is that we can see tumor response with this therapy, which shows that there is local tumor control potential. Second, if this patient were treated with standard practice radiation therapy with either a plaque or proton beam therapy, almost assuredly there would be long-term damage both to the vasculature and the optic nerve and probably the macula, and we would predict that vision would continue to go down quite significantly in this patient. And on the opposite, here we have retained visual function. So we can see that in the cohort of patients that are now being primed for entry into the phase 3 clinical trial, over a 24 period time, which is the longest time point out, we can see that there has been essentially no significant increase in the thickness of the tumor over time. These lesions don't necessarily shrink to nothing with this treatment. So it's a different mechanism altogether of how the tumor responds to the treatment. So the tumors themselves remain controlled. And if we look at the same cohort, again, that's going to be the entry criteria for the phase 3 study, the mean best corrected visual acuity definitely is not going down. In any significant way. Over time, there seems to be a trend towards a slight reduction in vision, but these are patients with central macular tumors or those just adjacent to the optic nerve that had you treated them with radiation therapy, we know that by historical treatments, this would have significantly reduced vision. So the favorable vision results needs to be balanced compared to patients that may have developed severe vision loss from radiation retinopathy. One of the interesting facets of drug delivery that I know your group has been really important and pioneering is that we can deliver drugs to the back of the eye in so many different ways. The current trial looks like on the right with intravitreal injection of the medication. It goes into the vitreous and then penetrates through the retina and reaches the choroidal melanoma. Another form that's going to be tested starting in July with the modified phase 2 protocol will be the use of the suprachoroidal delivery system. So we'll be delivering the drug bypassing the vitreous and going straight to the suprachoroidal space, which may allow us to treat actually larger tumors than before. And actually the expanded cohort will include the not included medium-sized tumors into this. So I think more information to come and great promise and advancement in ocular oncology, but maybe for all of oncology as there's applications to other tumors elsewhere. The main issue with uveal melanoma is that metastatic disease is still the problem. So I can tell you all the great things about how we're controlling disease in the eye, but we know that up to 50% of uveal melanoma patients will develop metastatic disease. There's been no effective change in survival for these patients, and there's no approved, FDA-approved treatment for direct metastases or adjuvant therapy to try to prevent metastases in this disease. There are numerous ongoing clinical trials, and all of the drugs that have been used with actually fantastic responses in cutaneous melanoma that is metastasized, so CTLA-4 blockade or PD-1 inhibition, have shown meager results or response rates in patients with metastatic uveal melanoma. So the huge unmet need in this disease. And currently now treatments for metastatic disease really have been repurposing the drugs that are used in cutaneous melanoma for the most part. So there are very few uveal melanoma specific therapies that are available for our patients, though some are showing some promise in clinical trial. So when we find a patient with the uveal melanoma, spend a lot of time not only treating the local tumor, but trying to get information about their metastatic risk. And the reason is that we've gained an incredible amount of knowledge in the genetics of uveal melanoma now over the past 20 years. Patients also want to know what their risk is, and this has been shown in surveys, but also in our clinical practice as well. The knowledge of whether I have a melanoma of low risk for metastasis or high is important because that might make me more eligible for entry into high-risk clinical trials, but it may also customize how you screen me or follow me with serial MRIs or how frequently you do that. Finally, knowing patients' genetic status may help us identify targets that allow for better treatment or development of therapies. We know that there's different ways to estimate metastatic risk. One is what we're all used to just in the clinic, so by using clinical features. Very big is bad, very small may not be so bad, things of such. Second is with histopathologic features, and a lot of this data comes from when eyes were predominantly enucleated. So we have a lot of histopathologic information over time, and that's been correlated with outcomes and survival. But now moving into chromosomal alterations, looking at whether there are changes in chromosome number, deletions or additions, can change the risk profile of a patient. And going into what's now considered to be standard of care and frontline screening is gene expression profile therapy, which we'll speak about. The interesting thing that's now happened is that the National Comprehensive Cancer Network, which provides guidance for clinicians, but also downstream for insurers and people that are paying for these tests, have been using a combination of these factors in order to stratify patients as either being low, medium, or high risk for developing metastasis. And there have now been recently published guidelines that now guide how frequently we need to do metastatic screening. So if you're a low risk patient of developing metastases, we may not need to do systemic screening as frequently. So this is both efficient for the patient and cost effective as well. And we feel that the data supports the ability to capture events as we need to. So you may have heard about gene expression profile testing in uveal melanoma. It's a very interesting test that's been developed over time. It's done at a CLIA certified lab, and the test has itself been approved. This is performed at the time of treatment where tumor biopsies are performed. RNA is isolated and expression assays are performed. And there are several bioinformatic cut points with gene expression profiling, which are unique to this test. Only 8 cells at a minimum are required to make the call in this test, which requires just very little tissue. And only 15 discriminating genes are required in order to assess the gene expression profile of our patients. And it has a very low technical failure rate. So taking a small sample, which is difficult to get in these melanomas, usually gives us an answer which can be helpful for our patients. The first area of collaboration that I was involved in is working with the group at that time from the University of at WashU with William Harbour. And this is the Collaborative Ocular Oncology group, which was the group that prospectively validated this multi-gene gene expression profile assay in uveal melanoma. And what I learned is that scientific discovery requires validation in large, diverse patient populations. So the gene expression profile testing distinguished into 3 molecular classes. So broadly, there was 2, class 1 and class 2, and then that's subdivided into 3 separate classes. Image here, this is the Kaplan-Meier curves that look at survival in patients that either had a class 1A, class 1B, or class 2 melanoma. And in all of medicine, when we're looking at predictive modeling, this is the most significant segregation that we can find in low-risk tumors versus high-risk tumors. This prospectively validated gene expression test now has 2 components. One is the class distinction, class 1A, 1B, and 2, and a new component called PRAME, which is an antigen that has now been shown to be a modifier of the genetic risk. So PRAME positive expression tumor has an elevated risk of metastasis than a PRAME negative tumor. And these are all commercially available and are done fairly routinely. What we've also learned from Harbour's lab is that there are 2 clusters of mutations that occur in uveal melanoma. This has really helped us to understand the evolution of how melanomas develop in the eye. The first cluster is considered an initiating event, and this is the activation of the GNAQ and GNA11 component of the melanocytes, and that's very unique to uveal melanoma. We do not see this in cutaneous melanoma. Again, separating the distinction between uveal and cutaneous. They have the same last name, but they're distant cousins, so they're biologically very different. So after that initiating event sends a melanocyte down the line towards developing into a nevus or then a melanoma, a second event has to occur in which there's progression events. So you've made it to the nevus stage, and now what happens kind of determines the fate of that cell. In class 1 tumors, there's either a SF3B1 mutation that occurs or an EIF1AX mutation that will occur. And that takes the lineage of that melanocytic tumor down to the lower risk class 1 lineage. Or the BAP1 mutation may occur, which is also located on chromosome 3, that then takes the patient to the high risk class 2. So putting this together, I'm a choroidal melanocyte. There is a mutation that occurs within me that then in the G alpha Q subunit that changes me into an early melanocytic lesion. So this might be something that may be the start of a nevus, a very small nevus, or a lesion that doesn't quite look like a melanoma. The vast majority of these will become a dormant, benign nevus, the ones that we all see in our clinic and follow on a routine basis with a yearly examination and take pictures. That's fine. But about 1 in 8,000 to 1 in 9,000 of these nevi can have a second event that occurs that changes them into a melanoma. So either it's this EIF1AX or SF3B1 mutation that changes the patient into a class 1A or 1B melanoma, or a more significant mutation can occur with loss of chromosome 3 and a BAP1 mutation that leads to a class 2 or high risk melanoma. So once you have these mutations in place, then that kind of leads to what we know can occur later, which is the risk of metastasis. Now, it doesn't just stop there. There needs to be other events that actually allow a melanoma in the eye to gain that potential to metastasize. And we know that gain of 8q can cause these low risk class 1 melanomas to metastasize. And typically it's about less than 10% within a 3 to 5 year period. But class 2 melanomas, which have already lost chromosome 3 and have a BAP1 mutation, need to have additional losses in both chromosome 1 and chromosome 8 to then subsequently have a higher risk for metastasis, which is quite significant. So what we've learned is the evolution of how a choroidal melanocyte then becomes a metastatic melanoma cell. And it has really been elucidated by a lot of molecular biology. And this information, I think, can be very helpful and provide targets for our patients. So for me, I'm a clinician. So, what is, are there practical considerations for clinicians using these gene expression profile tests in uveal melanoma? So when we all kind of started our careers, about 15 years ago, and Scott will remember this, we were all in great awe of the great ocular oncologists that have come before us. And, we would all kind of very dutifully listen to what they had to teach us. And it was rather quite intimidating. I'll say this as someone fresh out of training and starting my practice. So in the beginning, it may have been a little discouraging because understanding was hard to come by, but still collaborative, and we still tried to learn. So a bunch of us started kind of a pre-Zoom phone call type scenario, which we called the Ocular Oncology Study Club. So we would share articles, we would talk about practice patterns, how we code things, we would review difficult cases and get comments, and we basically commiserate on our journeys to establish our own ocular oncology centers. We had very few requirements. First, we all had to like each other, which was pretty easy. We had to be inclusive, and there could be no drama in the group, and I think we fulfilled those criteria very well. But this was really my second foray into the importance of collaboration in ocular oncology. So this morphed into the Ocular Oncology Study Consortium. So this was a group of individuals across the United States, and we had international folks well, and Scott was part of our original thought process in this, in which we came together to practical questions as surrounding gene expression profile testing and its applicability in clinical practice. So we had this group, we had a name, so now, so have a can work together in ocular oncology in collaborative studies. So we wanted to design and execute important studies that brought together our diverse training backgrounds, our diverse patient populations, and various techniques that some of us favored in treating our patients. We wanted the studies to be feasible and informative and help to guide clinicians as they take care of patients in clinic every day. Focused on outcomes of radiation therapy as they're related to gene expression profile testing. And we wanted this to be something unique and helpful for patients, if not revolutionary. So our methods required IRB approval at all of our study sites. These were adult patients with clinically diagnosed uveal melanoma. They had concurrent tumor biopsy for gene expression profile testing and subsequently placement of iodine 125 plaque brachytherapy with a minimum follow-up of 3 months. The cohort demographics were able to recruit 379 patients into our study. The median age, as expected, was around 62 years. These were mainly medium tumors as they were treated with radiation therapy, with the largest mean basal diameter of about 12 millimeters, and about 16% of the patients had ciliary body involvement. So a representative panel of patients being treated with radiation in this country. If we look at the overall configuration of the gene expression profile result for this population, about 47% were class 1A, 21% were class 1B, and class 2 tumors accounted for the remainder 31%. Interestingly, the technical failure rate, so the ability of us not to get a result, was only less than 1%. So this means that this is a very reliable test. When you go through the trouble of submitting the sample, you usually will get an answer back. If we classify this population based on the size of the tumor and stratify them either by the AJCC Joint Commission on Cancer Care based on stage, we find that most of these are stage 1 or stage 2A tumors. And then if we divide it by what we're more familiar with, which is the COMS or Collaborative Ocular Melanoma Study, the bulk of these are medium tumors, but about 10% were large and 13% were considered small by COMS criteria. Our first report looked at high-risk clinical features, ones that we traditionally associate with high risk, and how those correlate with gene expression profile class 1 or class 2. And secondly, does COMS tumor sizing, which again is a clinical parameter that we're all used to, correlate with the tumor features and gene expression profile testing. So when we look at the class 1 low-risk tumors for metastasis versus class 2 high-risk, we saw that there were about 113 class 2 tumors, and we found that there was highly significant involvement of the ciliary body and the presence of exudative retinal detachment in these class 2 tumors as new clinical risk factors that correlated with poor prognosis. If we then divided tumors by either small, medium, or large by the COMS criteria, we found that large tumors had a higher concordance with ciliary body involvement and exudative detachment. We found that small tumors were more likely to have drusen and followed as a nevus. So they were followed for a longer period of time as a nevus before initiating therapy. What we did was look at the relative percentage by the COMS criteria of small, medium, and large. And as we can see, as the tumors are getting larger, the percentage of those tumors that are class 2 or high risk for metastasis, not surprisingly, increases. And this was highly statistically significant. Now, looking at historical information, we looked at a 10 and 20-year study by the Wills group, by the Shields, as well as the COMS data looking at the percentage of patients with a metastatic disease at 5 and 10 years. So by small, medium, and large, we can see the darker colors show the risk of metastasis. Now, if we overlay our data, looking at class 1 and class 2, the dark purple really matches up quite well, especially in the medium and large tumors, with relative percentage of patients that have the high risk criteria. So what we're learning from this is that class 2 tumors, which are the ones that we predict by gene expression profile, occur in older patients, are larger, and have ciliary body involvement. That was kind of well known. But this study showed us that the presence of large exudative retinal detachment and anterior tumor location may also be a correlative factor for class 2 tumors. We know that gene expression profile status, if we stratify it by COMS tumor categories, provides a framework for prognosis, and this has an implication for patient counseling. So if we see a patient that has a larger tumor, we may be able to make a fairly reasonable prediction that this would be a high genetic risk tumor as well. The second area that we were all interested in was the use of melanoma biopsy, and both by technique and complications, as Scott, you get larger chunks of tissue and better analyze these tumors not only for diagnosis but for prognosis. There are really two different approaches of how we biopsy these tumors. The first, and on the left, is a transscleral approach. So here we've exposed the oblique quadrant overlying the tumor. We've done transillumination in order to see the tumor itself. And then we are cutting down with a blade. This is our apparatus in order to obtain our tumor specimen. And we're going in with a needle. Similarly, on the right image is a transvitreal biopsy. So ultimately, in both cases, we have a needle going into a tumor and we're aspirating the material out of the eye. But it just kind of depends on either surgeon preference or clinical preference. And there you can actually see the chunks of tumor within the tissue itself. and then we close. So two different ways to obtain tissue. And we were interested to know how and when these techniques were being applied. So biopsy approach varied across this entire study, with 64% of surgeons preferring on their tumors to use a transscleral approach with using a fine needle. But there was a variety of use of transvitreal approaches as well. What we found was interesting based on tumor location and technique. So anterior tumors, so tumors located anterior to the equator, occurred in about 68% of patients, and the technique used for those, probably because it's easier to access, was in 69% using a direct transscleral approach, so going from the outside of the eye through the base of the tumor into the tumor itself to obtain the specimen. Posterior tumors made up the remaining 32%, so posterior to the equator. And here, the majority of them, 62%, used a transvitreal approach, so through the pars plana into the vitreous, through the retina, and into the choroid. And this approach, based on the location, was significant. And size matters in uveal melanoma. So what we found is that the mean thickness of tumors biopsied directly by a transscleral approach was about 5.2 millimeters, versus those with the transvitreal approach tended to be smaller at 3.8 millimeters. And that was statistically significant. And this might be due to the fact that these more anterior tumors could have been thicker because they were growing longer, and the surgeon was more comfortable obtaining this with the transscleral approach, and needed the transvitreal approach to visualize the needle as it goes into the tumor for those thinner tumors. We found that the training of the ocular oncologist makes a difference as well. Dr. Oliver and I are both VR trained and also ocular oncology trained. And I think that impacts how we approach our biopsies. So vitreoretinal fellowship training in this subset of ocular oncologists predicted a tumor more likely to undergo a transvitreal approach for the bulk of their cases versus a transscleral approach. And it also meant that the tools of the vitreoretinal surgeon were probably more applicable, in that we tended to use wide field viewing systems instead of just using an indirect ophthalmoscope to guide the needle going into the eye. So this collaboration was quite interesting and fruitful, and we had several reports. But the key is that these were all in a real world setting. And ultimately, these papers have all been published, and shows that collaboration can come together. Another area of collaboration has now taken the original gene expression profile study and now taken it to the next phase, which is the COOG study number 2. And Dr. Oliver and I are both members of this study that is now NIH funded and is one of the largest collaborative studies in ocular oncology that has gone forward. There are 24 sites that have recruited patients now over the past 3+ years. As of January 2020, 1,448 patients have been recruited. And just as a comparison from the year before, there were 977, so about 500 patients within a year, which means that we are probably capturing a good 30 to 40% of all the new uveal melanomas treated in the US with this study. The bulk of the patients were over 60, as would be expected. And what we've learned is that the gene expression profile previous studies have held through. So about 66% of patients are class 1, and a third of patients are class 2 gene expression profile uveal melanomas. And what we're focusing on in this study is the expression of PRAME, as I mentioned, is a modifier of risk, and about a third of patients are PRAME positive. And what this study hopes to do is to validate PRAME as a marker, and then how do we combine PRAME and gene expression class to better predict for patients as well. There's also an arm looking at next generation sequencing to see if various mutation profiles within the tumor might better predict outcome for our patients. But really the main issue here is micrometastases. What tends to happen in our patients is that even before we diagnose the ocular tumor, we are worried that in some patients that a small cell or two has already left the eye and is floating around in the blood. So even before the time of ocular diagnosis, seen here in yellow, there is tumor tissue that has already left the eye. So even after we treat the eye, the patient still develops metastases. And that's because it already has gotten a head start. And I think that's the front part, the biology of uveal melanoma. Now, we may have some opportunities in terms of adjuvant treatment to try to treat these tumors before they manifest in the liver, or we have to direct our therapy once we have confirmed metastatic disease. But neither of these strategies have been quite successful in uveal melanoma. So just because I know I have a class 2 melanoma, we are unable to detect micrometastatic disease, and there is no actionable agents to treat these patients. So what about looking at tumor cells as they're floating around in the blood? And we call these circulating tumor cells, and it's been an area of great interest in cutaneous melanoma. A recent pilot study from MD Anderson looked at 40 patients who are high risk for metastasis and diagnosed with uveal melanoma. At the time of initial entry into the study, about 36% of them, about a third, had identifiable circulating tumor cells. And that still, when you follow that patient group, when they developed frank metastatic disease, so we know they have metastases, the circulating tumor cells were found in about 60% of patients. So that still means that there's a large gap in patients that even have frank metastases with detection of circulating tumor cells. So that strategy may or may not be a good way to try to capture which patients are in the active process of metastatic spread. So is there a better way to identify micrometastatic uveal melanoma? And this is where my journey has kind of changed from genomics to the field of proteomics. And again, my next collaboration has been with one of our faculty that joined at around the same time as I did from the University of Iowa, Vineet Mahajan. And here we are at one of our uveal melanoma 5K runs that we were hosting here at Stanford. So during one of our runs, we were chatting about this unmet need in uveal melanoma, and we have a central hypothesis for our studies, which is that eye fluid and serum protein signatures can provide an early determination of micrometastatic uveal melanoma risk accurately and more rapidly, and maybe even safer than doing a direct tumor biopsy. And the thought is that if you have a primary melanoma in the choroid, it is secreting proteins not only into the microenvironment of the choroid itself, but quite possibly through the retina into the vitreous. And those molecules may also be circulating tumor markers that we can identify in the blood. So proteomics has been a useful tool in medicine to identify what gets then secreted from the genome of these tumors. And in uveal melanoma, there have been several early studies looking at proteomic profiles of the secretome of uveal melanomas. These have been predominantly in nucleated eyes or cell culture of immortalized uveal melanoma cells. What they've shown is that there's differential expression of inflammatory markers, but it's lacking a shotgun approach or any targeted therapeutic solutions in these initial studies. So we felt that there's probably an unmet need in this field. So we were doing a study now that looks at prospective collection of vitreous from patients at the time of plaque placement. Since we do prefer using a vitrectomy-based biopsy approach, we're doing a 27-gauge diagnostic vitrectomy by collecting undiluted vitreous specimen as well as aqueous. And then when we collect the tumor specimen for gene expression profile testing, we're separating out tumor cells into our collection sample for our study. When we enucleate patients, once the eye is removed, we're doing a needle aspiration of the vitreous and the aqueous as well. And this is our proteomics pipeline for precision health in the setting of uveal melanoma, where at the end of this, we want to be able to have customizable therapies for our patients. So this is our initial cohort of patients with uveal melanoma that we've entered into the study. You can see that they all are melanomas of different sizes and shapes and configurations and locations, a variety of class 1A, 1B, class 2, and PRAME positive tumors. And we also had 3 control eyes that had vitreous at the time of epiretinal membrane surgery. So we were controlling for the fact that they actually had a surgical intervention as well. So the question is, we pull these specimens, we can't run them all on the same day, we have to bank them. So how do we do this? So Dr. Mahajan and I have been working towards establishing the Stanford Ocular Bio Repository, which has been an important tool in carrying this research forward. Because when we do these types of biomarker studies, not only is there hurdles to go through with regulatory compliance, you see the patient, collect all their clinical data, we go to surgery, we collect these specimens, but then now we have to get them to the biorepository and keep them safe before we do all of our well thought out laboratory experiments. So we developed an improvement on one of Dr. Mahajan's previous papers and created Morley. So Morley is the mobile OR laboratory interface. So Morley is a cart. So this is custom designed and resides in our operating room. It has several key features, including computer interface, worktop surface, a centrifuge, storage containers that hold all of our collection tubing, as well as a microscope in case we wanted to do any analysis at the OR table side. You can see the tubing that we use are coated so and we have portable dry ice containers that follow us into the OR. We established a REDCap database that our fellows have all been trained across all of our departments that allow for diagnostic categories as well as preoperative history that can be placed, and that it is in a secured, shared database for our researchers. So this is our Morley cart deployed not only in our main eye center, but in the main operating room at Stanford, and now recently in our children's hospital. And all this data is connected with the REDCap database. So when we go from Morley to the biorepository, we have various sample procedures. So the surgical procedure is put into these laser etched barcoded tubes. In the operating room, we have dry ice in these portable containers so that we can batch them through the course of a busy day of surgery. Then at the lab bench, they're then snap frozen and then placed into our storage repository. The barcode scanner allows us to then track these specimens, so they're placed in cold storage, but now we know exactly where they are. So in the future, if we want to look at all of the uveal melanoma cases, we can go exactly to where we need to find them. And this has really allowed for customization of our research process in this. In the first 6 months, we collected about 486 specimens, and I can say now that in 2 years, we have about 1,600 specimens from across the eye, including blood, anterior chamber fluid, and tumor and vitreous specimens that now we can analyze. So when we're looking at the protein biomarker discovery pipeline, there was kind of 2 different ways that we expanded this. The first is a more targeted proteomic platform. So here we looked at protein concentrations in vitreous fluid in this case. And usually these are usually done by a conventional ELISA platform, but we decided to use an antibody array that quantitatively measures about 1,000 individual proteins. And we performed this analysis on our initial cohort of uveal melanoma samples and control samples, which were the epiretinal membrane patients. And so we did a principal component analysis that first and importantly showed that the protein signatures in the red choroidal melanoma samples can be distinguished from control vitreous. So there is a difference in the proteins in an eye that has a melanoma of various sizes and shapes than a non-melanoma eye. So that was important. The second is whether we could use this information by protein analysis to segregate tumors based on their gene expression profile. And we were pleased to find that we could. So the proteins themselves segregate based on whether they're class 1, class 2, or whether they're PRAME positive or PRAME negative. So the next step was this heat map was helping us to make that determination. So this heat map shows protein expression on a logarithmic scale. And what's interesting is that this representation allows us to see differentially expressed proteins separate across these patients And proteins appear to be over or underexpressed based on their class 1 or class 2 or their PRAME expression. The next step was to do a more of a shotgun proteomic screen. So that really allows us to look at the entire proteasome and see, here we can see a similar trend in which there are over and underexpressed tumors that can segregate class 1, class 2, and PRAME positive tumors. So we were able to pick up biomarkers as well as differentially expressed metabolic proteins. And now these proteins provide us a tool to jump forward to construct protein signatures that are unique for our patients. So the question that we had is that in this initial screen, could we find the protein signatures that may predict metastatic targets that we can use currently approved FDA drugs to repurpose for choroidal melanoma? And this is our initial analysis where we took our findings and looked at patients based on GEP class and PRAME and looked at whether there were potential targets. And what we can see is that there are several current used areas of oncology that potentially have actionable targets in choroidal melanomas, at least in our samples, which gives us potential hope for detection of these in individual patients and then customizing the therapy based on the types of targets that reveal themselves. So future directions in our research are to continue to expand our cohort, and the use of the Morley system has allowed us to do so. We plan to then analyze our serum samples and compare that with what we find in the vitreous, and we're also collecting metastatic uveal melanoma samples from the liver to compare the proteomic profile there as well. And then our goal is to repurpose some of these agents and develop an adjuvant tumor treatment trial. So we've gone through a spectrum of kind of the current clinical care in uveal melanoma, the role of genomics, and now maybe an expanded role of proteomics in uveal melanoma. I think the future really relies on a combination of collaborations between ocular oncologists, scientists, radiation oncologists, medical oncologists, but all centering around the patient. So ultimately, I think the future is promising, though still a lot of work yet to be done. And I really hope that in the midst of all this changing world that we're in, our family can join your family up in the mountains in Colorado sometime soon. So I wanted to thank you all for this opportunity to be able to join you this morning, and look forward to any discussion. Thank you.